the college lecture for today. It's my pleasure to invite Dr. Chaturika Dandeniya, MBBS, MD Medicine, MRCP UK and MRCP Rheumatology. She is a senior lecturer in medicine and honorary professor in rheumatology and rehabilitation attached to the Department of Medicine, Faculty of Medicine, University of Peradeniya, her own alma mater. She enjoys teaching undergraduates and postgraduate students, and her main area of research interest is in lupus. She worked for a short period of time in Badulla during her training, which left a deep impression about working with minimal resources. She advocates rational use of minimal investigation in patient management in rheumatology, and has chosen the topic today as the conundrum of rheumatological disease amid constraints. And of course, she is the immediate past secretary of Switzerland College of Physicians.
So the topic that I thought about talking about today is about how do we get about diagnosing rheumatological diseases amidst constraints. Because I think this is a very important area, because rheumatology is not one of those areas where investigations come cheap. They are very costly, and I would say out of the city limits of Colombo, I would say almost virtually non-available, because like here you do enjoy the ever presence of the Medical Research Institute, the MRI, which gives you investigations at least like the ANA and the anti-CCP antibody, while like if the once you cross the city limits of Colombo, it's as good as on Mars, so you don't have anything. So then how do you go about diagnosis? So basically, even though I have titled this as rheumatological diseases, given that I only have half an hour, I thought I'll talk only about the autoimmune rheumatological diseases. So the scope, so what I will be taking you through today would be why should we accurately diagnose in rheumatological disease? Or should we accurately diagnose? Then the limitations in the resource poor settings and what should we do about it? So I will answer these questions through discussion of a few cases. So all these are like truly my patients in the hospital. So these the first case was a 35-year-old female who came with a history of inflammatory polyarthralgia for a period of 3 months. Her symptoms were fairly symmetrical and involving the small joints of both hands, with an early morning stiffness lasting for more than 1 hour. On examination, all the PIP joints, the proximal interphalangeal joints, were tender, but there were no swollen joints. And the bilateral metacarpophalangeal joint squeeze test is positive. So this is considered a pretty specific test for detecting synovitis in the early stages. So what you do is basically you hold the MCP joint side to side and then you squeeze it horizontally. And if it is positive, the patient will complain of pain. So this was positive on either side. And the initial investigation, this was what she came with, was an ESR of 50, a hemoglobin of 11, and the platelet of 490. So the question I'm going to ask is, what further investigations do you need in this patient? Because basically this is a patient with inflammatory arthralgia, but not really arthritis. You can't really say it's arthritis because clinically there's no synovitis that you can detect. So the examination, other than the tender joints, there's nothing else. So I would first like you to answer these questions. So why should we investigate in clinical medicine in any case? To confirm or refute a clinical diagnosis, definitely yes, but I here say to confirm or refute a clinical diagnosis, which means investigations should always be there to complement your clinical diagnosis. It's not an alternative to a good history and an examination. The secondly, to establish the suspected complications of the condition that you are thinking that the patient is having. Yes, in some cases, you can have an idea about the prognosis of the condition through investigations and, of course, particularly in rheumatology, to assist with the management because we do all these monitoring investigations. So with that, coming back to our case, so what further investigations do you need to decide on the treatment of this patient? For the first purpose, okay, these are what could be done, not that what I did, these are what could be done. So to confirm or refute the clinical diagnosis, okay, you can go ahead and do a rheumatoid factor and anti-CCP antibody. And if really needed, you can also do an ANA, HLA-B27, because this could be a peripheral spondyloarthritis. You can also ask for an ultrasound of the hand joints, which is how the world is moving towards, a vitamin D level, and a CRP, because kind of the differentials. To establish the suspected complications, you can do an X-ray of the hands to see whether there are erosions already set in. And given that this is an inflammatory arthritis, mind you, she didn't have any lung palpitations. However, you could choose to do a chest X-ray because these are what my HOs are doing nowadays. And to prognostify, you can think about doing a rheumatoid factor and anti-CCP antibody, because if these are positive, very likely that this patient is going to evolve into a full-blown rheumatoid arthritis. And to assist with the management, okay, renal functions, liver profile, TB screening, hepatitis B surface antigen, and Hep C antibody, because we are very fond of like adapting international guidelines to our setting. That's what we do. So if you go through different international guidelines, particularly the ACR guideline will say, the American College of Rheumatology, before starting DMARDs, you have to do Hep B surface antigen and Hep C antibody. If you go through the Japanese College of Rheumatology guideline, they say you have to do the TB screening prior to starting methotrexate. So how many of you do this? But like if you want to do, you can do. But what did I do with this particular patient on the first clinic visit? So on the first visit, I did nothing of this. I just started on treatment for early inflammatory arthritis, because this is enough evidence to say that she has early inflammatory arthritis. The correct age group, she had an inflammatory arthralgia, polyarthralgia, fairly symmetrical small joint onset with an early morning stiffness lasting more than 1 hour. The ESR was raised, MCP joint squeeze test was positive. What else do you need other than saying, okay, this patient has an inflammatory arthritis? And if I went on more specific, if I say waited for a rheumatoid factor, is that going to change anything? Or in my starting the methotrexate, my decision to start methotrexate, would that have changed anything? Not really. So on the second visit, I requested her to come with the following investigations, if possible. Only this. So to confirm or to review the clinical diagnosis of possible inflammatory arthritis, I said, okay, do a rheumatoid factor, and the same goes for the prognostication. I did not ask for an X-ray of the hands, but because again, even if she had erosions, would my management have changed? Not really. Even if there were erosions, I would still treat her with methotrexate. No erosions, methotrexate. And to assist with the management, again, this is an important message for the registrar. Supervise your juniors. When they write renal functions, think, do you need the renal functions or do you need the serum creatinine? Just if the creatinine itself is enough, don't ask for renal functions. Just say creatinine. And of the liver profile, because we are operating in very, very constrained situations, I just ask for the ALT. So this is what I do for the monitoring in the clinic as well. Not the ideal, but this is what we have. So the serum creatinine and the ALT, and I added a full blood count. And that's it. So on the second visit, when she came with these investigations, the patient was feeling much better. The symptoms were gone. However, the rheumatoid factor was negative. Now what? What should I do next? You have the option of doing the ANA and the dsDNA and the HLA-B27, because I have seen this being done quite commonly. But I want you to see this, because as I told you, like when you move away from Colombo, move away from the National Hospital of Sri Lanka, you will not get any of these investigations free in the state sector. Because here at least you have the ANA through the MRI, you have the rheumatoid factor through the hospital. But move 50 kilometers away, you will have none of these. So then you need to invariably resort to the private sector. So the patient's out-of-pocket expenditure, and these are the costs as of December, like updated costs of investigations from a reputed, validated immunology lab. I say reputed and validated, otherwise you can just do an immunological test, which will be money down the drain. You will have a negative test, which is not going to tell you anything. So rheumatoid factor, latest agglutination has gone out for a long time now, although many labs still do. So what we do is the rheumatoid factor ELISA with the theta, and the cost of that alone is 2,170 rupees. You can say that. And an ANA, if you do with a theta, is 9,430 rupees. It's extremely costly. And the other thing, HLA-B27. Again, I see this being very frequently done. It's 11,500 rupees getting an HLA-B27. And the myositis antibody panel, 70,000 rupees. So do we have the luxury of indulging in all this is my question. So if somebody gives you a sample of water and asks, is this seawater or brine? You can just taste it and see, okay, it is salty, so it must be seawater. Or you can choose to run a battery of tests and say, okay, this is seawater and it is coming from the Pacific or the Atlantic Ocean. But that was not the question. Is that seawater or brine? Just tasting the water, just the tip of your tongue would be enough to do that. So why waste all that resources is my question. Because if it is if your question is to decide and treat this patient, whether this is an inflammatory arthritis or not, for the initial management, it doesn't really matter whether this is a spondyloarthritis, seropositive rheumatoid arthritis, or if you really want to say seronegative rheumatoid arthritis, it doesn't matter. Because in the initial stages, the management is the same. Your conventional synthetic DMARDs that you start the treatment with are going to go still in the same order. It's going to be methotrexate, leflunomide, sulfasalazine, and hydroxychloroquine. It's not going to make any difference. When the difference is going to come is if the patient does not change, respond to the initial first line management and you want to go ahead with the biologic, then yes, it is important for you to decide whether this is seropositive or negative, because certain biologics do not work in seronegative disease, such as rituximab. It does not really work in seronegative rheumatoid arthritis. So then it is important. But then how much is the percentage of patients with rheumatoid arthritis who need to go for biologic in the future? It's only a minimum. So until you have to cross that bridge in constrained situations, try not to resort to too many investigations. You don't need all that. The second case was a 25-year-old female who presented with fatigue and was found to have anemia. So the further evaluation revealed an autoimmune hemolytic anemia. So you know that autoimmune hemolytic anemias, if you ask your blood bank and your hematologist, they will give you the profile of the autoimmune hemolysis. And she also gives a history of 6 months of excessive hair loss, but other than that, there were no other abnormalities on history or examination. The basic investigations, other than showing an autoimmune hemolysis with a raised ESR, normal CRP, and a UFR, and she also had a bone marrow biopsy that was consistent with hemolytic anemia. Her ANA is positive, 1 in 160 in a nuclear homogeneous pattern. So you have a young female with an autoimmune hemolytic anemia, raised ESR, normal CRP, excessive hair loss, and a positive ANA. And the positive ANA also is in a nuclear homogeneous pattern, which you know is the staining pattern for either the anti-histone antibodies or the anti-dsDNA antibodies. So what is the diagnosis and what further investigations do you need for this one? So when I ask you, what are the options? Okay, again, these are the available options. What you can do, you can ask to confirm your diagnosis, double-stranded DNA, anti-Smith antibodies, and the complement C3, C4 levels. And to establish suspected complications, I would say, given that there are no other clinical features, sensibly you would do nothing. To prognostify, yes, the dsDNA titer and the complement C3, C4 levels will be helpful. And to assist with the management, again, your decision being to start on disease-modifying drugs, all the rest that I told you earlier. But what did I do? I could afford to do the complement C3, C4 levels because it is available at the TH hospital, at TH Peradeniya, and I did that, which came back very low. Because it is an investigation that I don't consider as a waste of money in this particular patient, because for one thing, it helps to confirm the diagnosis and it tells me what is the intensity at which I need to go with the immunosuppression. Do I go with a bulldozer or just a slap on the head is enough? That's what it tells me. And to assist with the management, again, which I modified to serum creatinine and ALT, was enough. So this is what I did. So my question is this SLE? So when in the earlier talk, even Dr. Manavdev was taking through the difference between classification and the diagnostic criteria. Remember, in rheumatology, most of the conditions do not have diagnostic criteria, but you have a classification criteria that completely two different kettle of fish. So classification criteria, you apply only to conditions where there is already a clinical diagnosis. And the aim of applying the criteria is to see whether the patient fits in a clinical trial or not. That's it. You do not wait until the patient ticks all the boxes to see this is SLE. I always tell my registrars, if you want to wait till you tick all the boxes, the diagnosis will be given by the JMO, particularly in SLE, because SLE is like a ticking time bomb. The patient can die very easily through organ system involvement. So you don't wait until all the boxes are ticked. So this case, to me, even though like if you go through the classification criteria of the 2019 ACR EULA criteria, the patient will score only 6 because she has non-scarring alopecia and autoimmune hemolytic anemia. And without, if you didn't have the complement C3, C4 levels, this will score only 6 out of 10. So you know without a 10, you cannot classify as SLE. But to me, for all intents and purposes, this is SLE. This could be evolving SLE. So if you really want to label it, if you really want to give it a like a boxed label with a nice bow on top, you can say, okay, this is an undifferentiated connective tissue disease in the lupus spectrum. Because we know like autoimmune hemolytic anemia, hair loss, this is more likely to progress towards lupus. So in that case, we say it's in the lupus spectrum, but it's still an undifferentiated connective tissue disease for the sake of having to give it a name. But then, is the management going to change based on the name? I would leave you to think that. And the third case was a 40-year-old female. So this was again an actual patient from Polonnaru who came complaining of shortness of breath that has been limiting her life as a farmer's wife. On examination, she is found to have bilateral harsh fine fractures in the lungs, actually the lung bases, and the chest X-ray is compatible with interstitial lung disease. Further into the history, it transpires that for the last 2 years, she had not really been well. There had been one thing after the other. And she has the initial symptom was excessive hair loss, and then inflammatory type small and large joint arthritis and proximal muscle pain and weakness. So you would agree here that this is a bit more like a difficult case because things are propping up from here and there. So there are some features of an inflammatory arthritis. There's an ILD. There's muscle weakness, proximal muscle weakness as well, and muscle pain, and excessive hair loss. So like things from different diseases. And on examination, additional findings other than these include proximal muscle wasting, synovitis in bilateral MCP and PRP joints, and non-scarring alopecia. So this history is confirmed on examination. And these are the investigations, which will be even more confusing. You have a raised ESR and a CRP, both are raised. Full blood count showing a mild anemia with normal red cell indices or a normochromic normocytic anemia with a high platelet and a normal WBC. CK was 1090 international units per liter, which is obviously elevated. The ANA, she came with this report, which was positive, 1 in 320, nuclear homogeneous and cytoplasmic mixed pattern. Again, so like the exact antibody association is difficult to say. What you can say is maybe dsDNA is there, but there are some cytoplasmic antibodies as well. And by the time she came to me, so 2 years of being investigated in and out of the hospital, she could no longer afford any further investigations. So, do you have a potential diagnosis? Okay, all I would say is there's something autoimmune going on. Something autoimmune going on. It could be Kamalavati or Somanavati or Ukuama. There is something autoimmune going on because there's hair loss, there's obvious inflammatory arthritis, raised inflammatory markers, proximal muscle wasting and weakness with a raised CK level. So clinically, this could be an overlap syndrome of SLE polymyositis, and probably in the mixture there is some rheumatoid arthritis as well. Again, do you need any further investigation to start treatment is my question. I would say no. What you need to do is, okay, if you identify that this is something autoimmune and rheumatological, find one drug or a drug combination that is going to address all the systemic manifestations. In this case, something that would work for all of lungs, muscles, joints, and hair. Now, for example, if you take mycophenolate notoriously does not work for joints. So it does not come here as a treatment option. Methotrexate will be a good option. Actually, she was on that, but could never escalate to a proper drug dose because her ALT-AST started going up. So any other investigations which you can arrange at the hospital which can help the diagnosis. So other than resorting to the private sector immunological investigations, anything else that you can do in the hospital? I would say do a muscle biopsy because she has proximal muscle wasting and weakness and an elevated CK level. Because most of the hospitals at the moment, like the higher grade hospitals, do have pathologists. So you can do a muscle biopsy potentially. And if you have access to a electroneurophysiologist, you can get an ENG done. They are not that much of a dying breed at the moment. So you can get done, like at least after transferring to the patient to the nearest teaching hospital. And bottom line is, whenever possible, try to go for a histological diagnosis. It is more specific. Now, if you're listening to Manavya, she was taking about like the ANCA positive vasculitides. Ultimately, the most specific diagnosis comes from the tissue. So wherever it is possible, try to get a histological diagnosis, which is available and affordable. So what happened to this particular patient? So by the time that she came to me, 2 years of the multiple disciplines fighting with each other, trying to decide what was the actual diagnosis. The only thing that was happening was that she was being back to back with steroids, because nobody could make up their mind what exactly was the disease, and everybody was giving her steroids. And by the time she came to me, she already had an avascular necrosis of the left hip, so she could barely walk. So I stopped trying to diagnose exactly what was the disease and started the patient on rituximab. Now her disease is complete in remission, but she still cannot walk because of the hip. And now she's awaiting a hip replacement. So this is the final case. This was a 5-year-old girl whom I saw sometime last month, who was referred from the pediatric intensive care. So she had a history of possible vasculitis. She had a history of fever for 3 days, followed by gradual deterioration of the conscious level and later seizures. That's why she was there in the ITU. And while there, she developed gangrenous patches of 2 toes, 1 skin lesion on the abdomen, and the right pinna. The pinna lesion was actually bullous lesion. And she had been seen by the dermatology team there, and who suggested the possibility of vasculitis, and they requested further investigations and a rheumatology opinion. That's how she ended up in my lab. So the ESR was 90, the CRP on admission was 6, but by the time I saw her about 1 week into the admission, it was 36. Full blood count was normal except for a mild anemia, and the blood picture showed, as always, infection/inflammation. That's all it said. And these were the investigations that were being planned by the time I saw her. So according to the dermatology opinion, they were going to send an ANA, ANCA, hepatitis B surface antigen, and a procalcitonin. So these were on the cards. So the clinical picture. To me, this was most likely an infection-associated bullous vasculitis, because the onset was about, say, the skin lesion started about 5 days into the infection. There were typical bullous lesions, and there was like the involvement of the skin suggested a small vessel involvement. So calling a dog, to me, it looked like an infection-associated small vessel bullous vasculitis. So the differential diagnosis, the dermat team had also suggested that polyarthritis nodosa was a possibility. So agreed, it is a possibility, but although there were no other clinical features in favor of that. But what I would say very unlikely was SLE, because there was no other clinical features, only a very short 1 week history of febrile illness followed by all this, no other clinical features. So I would say ANA, because ANA can, like SLE can cause a vasculitis. They do get a complement-mediated vasculitis in SLE, but SLE vasculitis generally happens in those who have long-standing disease, poorly controlled. And this is the sort of patients, not with just a 1 week history coming for the first time with vasculitis. ANCA positive vasculitis, less than 16 years, it's almost unheard of. If you go through the world literature, they will tell you less than 16 years ANCA positive vasculitis is extremely uncommon. So try not to diagnose in adolescents. It's very, very uncommon. So in this case, of the initial plan investigations, ANA and the ANCA would not really add much information in this particular patient. But the cost of these two is about 20,000 rupees, the minimum. So if you go for an ANA without the teacher, it's about 20,000 rupees, because ANCA, to be of any use to you, you have to ask for the ANCA teacher, not just the C and the P ANCA. If you just ask C or P ANCA, they will tell you whether it is positive or negative, which is going to be utterly useless, because even in inflammatory bowel disease, you can get a positive ANCA. It will just say positive. What you need is a quantitative assay. So the quantitative assay is an ELISA, which is 16,000 rupees in the private sector at the moment. So it's very, very expensive. So the social background of this patient, her mother was basically by this time housebound. She is a diagnosed patient with schizophrenia, completely defaulted treatment, so she was housebound. She was the only child in the family, and the father was a manual laborer, and because of the condition of the child and the mother, he had been completely out of work for nearly a month and a half by this time. So if I did ask the father, okay, you still need to do this, do you think that he would not have done it? He would have sold something at the house and he would have gone and done it, because your only child in the ICU, what, as a parent, what could you do? But then, is that money well spent? Is my question. So I asked them not to do any of those. We didn't send any of these investigations. But is there any other investigations that can be done while the patient is there in the ITU? Yes, there could be a skin biopsy. There is a skin lesion. So I told you, like, if it is a vasculitis, try to get a histological diagnosis. So the skin is obviously involved, so skin biopsy. That's what we went for. But the next question is, would I wait for the skin biopsy to result before I would start on treatment for this patient? I would say no, because vasculitis is like a burning house. You have to act promptly. Otherwise, what you are left with is just a burned down skeleton, nothing else. If you wait on investigations to start treatment. So if you're asking for a skin biopsy now, if you are talking about infection-related bullous vasculitis, you need to do immunofluorescence. So for the immunofluorescence stains to fix and to process the sample, it's going to take a minimum of 1 to 2 weeks time, which we don't have. We nevertheless went ahead and did the biopsy and started the patient on IV methylprednisolone and IV immunoglobulin. And last week, I saw the child in my clinic. She came walking. She's very well now. But still, the skin biopsy is not available. I'm still waiting for the report. So in summary, the accurate diagnosis in rheumatological disease, I would say, is a luxury. In this, like, kind of the starved and the constrained setting like us, even though you may not have an accurate pinpoint diagnosis, it will not take much away from the management. And you saw the limitations in the resource poor setting and what can we do. So this is something I tell very often to my registrars. Try not to investigate to sate your academic curiosity, because that will be at the expense of the patient. If you can pay out of your own pocket and if it does not harm the patient, then that's fine. Otherwise, try not to. And litigation, so this is what people always put forth when I say, like, what about the litigation issues? I say, if you have an honest discussion with the patient and the family and tell them this is why we do this and not that, not the other, most of the time that would just do. Thank you very much.
Now, vitamin D level, as that investigation is extremely expensive, and almost all the reports that I have seen done as a screening is always low. So, what does the vitamin D level get any impact on the rheumatoid arthritis? Why is that listed there?
That was a very good question, because that is the one investigation that I never do personally. Because it is done commonly because patients who are having vitamin D deficiency actually do come with joint pains. They come with like very non-specific joint pains, like in this case. They can come with joint pain but no synovitis. So as a differential diagnosis, because you have it, I have seen this very frequently done. But if you look at the cost, one vitamin D level costs 12,500 rupees. And if you go through the health bulletin published by the Ministry of Health some years ago, I think about 3 years ago, they said 90% of the Sri Lankan population is deficient in vitamin D. So if 90% is deficient in vitamin D and replacing vitamin D for a month, the high dose replacement, the cheapest you can go is 600 rupees. You can give an IM injection 200,000 units, only 600 rupees. And if it is not toxic, why bother testing? I generally, like, if I suspect clinically, I just treat and see whether there's a therapeutic response or not. Because for another, I once had a chat with a chemical pathologist who told me that the lab sensitivity and the specificity levels of the vitamin D that we do is actually not very high. So it is for all intents and purposes, doing vitamin D levels is actually a loss of money for a situation like ours. So even when it is available in the hospital, because like I was also once a very enthusiastic senior registrar. So when I was in SR training, there was once this guideline which came out saying that all patients with rheumatoid arthritis should have replete vitamin D levels. Can't remember the exact reason, must be to counteract the osteoporosis that comes with rheumatoid. But then we started checking the vitamin D levels because I was here at the National Hospital and we had vitamin D levels done at the hospital. About a month later, I got a call from the chemical pathologist who told me, why don't you just replace everybody, because every sample that you send us is deficient and the test costs us 8,500 rupees. This was back in 2015 or 16. So that is the answer to that question. Try not to do.
Yes.
About vitamin D, I was just wondering, we also always see the report showing insufficient or deficient always, but are all Sri Lankans, if all Sri Lankans are deficient and insufficient, we are not showing symptoms, could the cutoff not be validated to our population, and could this be the normal level for our population?
That is actually a very valid question. I would say maybe a good study for us to do in the future. But if I give you some values now, for one thing, don't think that they are not symptomatic. What happens usually is most of the patients are actually females, and they go with pains without complaining. And once you start replacing only, they find out, like that was for me too. Because this same thing happened to me. Like there was a time when my husband came home in the evening, I could basically kill him because my whole body was hurting. Just paracetamol, nothing was helping. And like after some time, I just found some samples of vitamin D, took it. And 2 days later, I was like a new woman. Then only I realized, okay, all this was due to vitamin D deficiency. That is one. And so it may not be as asymptomatic as we think. That is one. And the other is if you look at the available data for osteoporosis for Sri Lanka. So there is one study published by Professor Lekam Wasam and the team in Galle. In Galle, where they have sunlight, say like 12 hours of the day most of the time. The prevalence of osteoporosis over the age of 50 years is 60%. 60% of the females over the age of 50 years in the southern area, the region that they did had osteoporosis. So I would say that is an alarming value. So vitamin D deficiency may be more common than we think. And yes, the values may not be validated for us, but still I think it is worth taking note of.